actually is there actually is a lot of variability between the type of intervention that gets provided, the quality of that intervention. And so I think when possible, to help patients be informed consumers, to be informed yourself in terms of what you're making a recommendation to. This can be really helpful to kind of understand the nuts and bolts. What is cognitive behavioral therapy? What is relapse prevention? How do they fit together? Where do they fit within the stage of treatment or the course of treatment that you might be providing? And then that also being said, CBT really lends itself to being able to pull out specific skills or techniques that even if you're not doing the psychotherapy, you could include some of these techniques in the routine care that you're providing as part of a med management protocol. Particularly some of the stuff I'm going to get to in the latter part of the lecture. I'm going to give you some actual worksheets and some things that can be useful to add in to whatever kind of intervention you're doing with patients who would benefit from some relapse prevention. So I just want to give a very quickly overview of the components of CBT, so you have an idea of what those are and kind of how that would be broken down. So that way, if you're talking with somebody and they're coming back and telling you, oh, I'm doing CBT, but you're getting a very different story than what I'm going to share with you, it's possible that the therapist isn't using a protocol, or they're not sticking to what would be an effective dose of that intervention. So I want to just give you some nuts and bolts of that. And then I'm going to go and talk in more detail about things that you can use that are part of CBT relapse prevention, particularly trigger identification, kind of why you would do it, how you would do it, urge and craving management, behavioral contingencies, and high-risk situation planning. So those are some of the techniques that fall under this that I think can be helpful for any level of provider to use. So the first thing to understand is, when would we use CBT? When would the components of relapse prevention, which fall under the umbrella of CBT, where would those fit? Because we don't want to be just, again, kind of throwing any type of psychotherapy at patients. It's important to know where they are in their stage of change and be able to match the intervention to that to be most effective. A lot of CBT is very skills driven. It's very, we provide the psychoeducation, then we provide the skill, we practice it, we encourage them to practice it at home in between sessions. If a patient is in pre-contemplation or even contemplation, that's not going to be the most useful set of therapeutic techniques to provide to them. They're not likely to be receptive to that information, to use those skills. They're not very likely to practice them outside of session. So where we really find this gets the most bang for its buck is when we get into action, and particularly maintenance. And that's where relapse prevention really shines, is once patients have started to make changes in their use behavior and they're wanting to take that even further, they're wanting to maintain the changes that they've already been successful with, that's where these techniques can be super, super helpful. Another way of kind of thinking about it on sort of a stair step is people that are in that kind of pre-contemplation, contemplation, harm reduction is going to be your best bet. So we're really just trying to help people be as safe as possible, build rapport, make sure that they feel that there's a trusting relationship here. You're not judging them with whatever their use is. Things are not contingent upon that use behavior, but you just want them to be safe, to use safely. Once they're kind of in that, I'm moving into action, I'm ready to make some changes, that's when CBT can be most effective. And that's where we're going to work through a process of teaching them kind of in order. And most of the manuals are going to walk through a type of order where we help them to identify what their triggers are, internal, external, where we help them identify what are their high-risk situations and be able to manage that on a daily basis, where we help them to identify ways that they can have alternatives to use, that they can manage cravings and urges, that they can deal with situations where there are high levels of trigger and they have alternative plans for doing that. And then they can begin to expand into other domains of recovery. So looking at things like, how do I engage with family and community and vocational and those types of things, right? So cognitive behavioral therapy is a talk therapy. So it's really about, and I'm going to show you a graph here in a second, teaching patients how to be experts in their own ability and understanding the links between what they think, what they feel, and what they do. And this type of therapy has really good evidence for treating all forms of addiction, behavioral addiction, every form of substance use. It's highly flexible. You can implement a full protocol, or you can just pull out different pieces, like some of the techniques I'm going to show you. It is intended to be short term. Somebody is not likely to be in CBT for years on end. That's more going to be supportive counseling. CBT is really about 12 to 25 weeks. A lot of the research says we hit a cap in terms of its effectiveness, kind of around that 25 to 35 range. So if people are not getting better and they've received that much intervention in CBT, and it's actually, pretty stereotypical CBT, then that's not the right modality for them. So it's really meant to be short-term, highly focused, and it can be combined with other therapy modalities. So this is a visual of what most of the skills in CBT are intended to teach patients and then allow them to intervene on their behalf to make the types of desired changes that they want. So it's breaking the process down of there's something that happens. Usually it's outside. So in this graph, it's an environmental trigger. So something happens outside of me. So like somebody cuts me off in traffic, right? That's a thing that happens that then triggers a thought. I always have a thought before I have a feeling. So that thought might be, what a jerk. And then that emotion that follows it could be anger. And then I have a physiological response as a result of that emotion. So my heart rate might increase, my respiration might increase, perspiration might increase, and then I'm going to engage in a behavior. So I might speed up, honk the horn, flip the person off, whatever is going to happen. And this happens within the course of seconds that this loop completes itself. Now, when we're trying to help people make successful changes in this complex, web of things that happens within seconds, we're not going to be super successful at helping them to intervene at the level of emotion and physiology. There's certain things that we can teach to help them self-regulate, but they have to practice that multiple times throughout the day. Where we are going to get a lot of usefulness is teaching them the process of intervening at the level of thought and behavior. And you can see that these things are bidirectional. So if I can change the thought that I have, that's going to change the emotion that I have, and then that's going to change the behavior that I engage in, and vice versa. If I change the behavior that I engage in, that's going to change the emotional experience, and it's going to change the way I think or perceive that event. So a lot of the work that we're doing in CBT is helping empower people with their own self-knowledge to know what their particular behavior chains are, and to be able to challenge them and replace them with more effective chain of behaviors. So all of the sessions in CBT are intended to be pretty structured, and they're broken. Typically, it's a 60-minute or 55-minute traditional therapy session that's broken into 20 sub-sessions, 20-minute sub-sessions. And we're always trying to balance, we don't want to be overly mechanical or rigid, but it's also not a supportive therapy. So it's not patient-directed, it's collaborative, and that the therapist comes in, there's an agenda. We're meant to cover that agenda for that day. And you do a lot of skills practice in the session, and then there's homework assignments or practice assignments that they go home with in between sessions. So it's really meant to be a little bit more like a coaching or a teaching model than it is traditional, come in, how was your week, tell me how it's been going. So the 20 minutes are broken into the first 20. We set the agenda, we go over what's going to happen, we get a little bit of information about what happened in the prior week, particularly with their use behavior. So that way we can integrate it into what we're going to be practicing today. We review any practice assignment that was assigned the week before. It's really important to follow up on that and check for understanding, did they use it? The next 20 minutes is where we actually introduce the new skill. So some of the skills I'm going to show you in a minute, we might spend a whole 20 minutes going over that skill, providing the rationale. Why would this be useful for you based on what you told me happened last week? It could give you this, this, and this. Let's practice it. And then the last 20 minutes is where we actually do the exercise, have them see how this could be useful for them. Maybe they fill out the worksheet. Let's say it's trigger identification. We might do a functional analysis with them. They would fill it out for a recent time when they used, and we get a lot of information about what are their internal, their external triggers. They get practice using the worksheet, and then we give it them several blank ones to take home to practice with. So that's every single CBT session is intended to be built in that order. There are some challenges inherent to doing CBT. It can be really difficult if you're switching from a supportive modality into this, because it's a big change from what clients are really used to doing. I come in, I vent, and I talk about how my week has been. CBT is really more about we're gonna take all of this frustration and difficulty that you're experiencing in your life and give you a set of skills to be able to manage that more effectively. So we're not going to give a lot of airtime to really processing or talking or venting about that kind of stuff. And research is pretty clear that that isn't all that helpful for people, especially when they're in the action phase, when they're really ready to make changes. Continuing to perseverate on the things that aren't working well are not necessarily that useful for them. So it can be a challenge for the therapist to not fall into that old pattern, and to be able to strike that balance between how do I maintain rapport, keep their trust, help them to feel understood, and that this is connecting to their life, but at the same time sticking with my agenda, recognizing I have a plan that we need to go over today. There's a specific reason why we're doing this, and making sure that that I don't deviate too far. So a couple of things that are really important to CBT. Number one is repetition. So recognizing that behaviors are based on habits. Habits are deeply ingrained. They are really hard to change. No matter who you are, what walk of life you're coming from, making a behavior change takes a lot of intention and effort and trial and error. And so we will repeat whole sections of sessions, whole sessions as needed. Concepts will be repeated, recognizing that a lot of our patients have issues with trauma and other comorbid mental health conditions that affect their cognitive capacity. So their ability to get things the first time could be limited. So we're never afraid to just repeat whole sections, whole concepts, and continue to go over it, because it's important that the patient gets it and can use it before we move on. It's also really, really tantamount to giving a clear rationale. And this is part of good trauma-informed care as well. We never force patients to do anything. It needs to be their choice. So they need to understand why this skill is important to them, how it's going to benefit their life, how it's connected to the difficulty that they're expressing, or they're not going to use it. If they don't know why this is useful, they might be a good patient and practice it with you, but then it's going to go in the garbage or the backseat of the car the second they're done with you. So they need to really have this be like, oh, this makes sense. I want to use this. This is an important tool in my life. And so usually when somebody isn't practicing something outside of sessions, because we haven't done a good enough job giving the rationale for how it's going to benefit them. Another important concept is making sure that we're monitoring. There's multiple ways of monitoring progress or completion of tasks. But if we ever assign something, we have to follow up with it. If we don't, then what we've just taught the patient is that it's not important. So we always follow up at the beginning of every session. What did we assign from the previous session? And we're always monitoring whether it's a mood check, or it's like something like a PHQ-9 or PHQ-2, or just something that we're using as a temperature gauge for how they're doing to track progress over time. So that's a big piece, because that's what helps us know if what we're doing is useful, if we're on track or not. We also really, really want to be aware of how do people change. And a big piece of that is reinforcement. And so we want to praise approximation through a process that's called shaping. We're not expecting big change over time or all at once. Sorry, we're expecting a small incremental change over a long period of time. And so anytime a patient does anything that approximates what we want to see, we give lots of positive reinforcement. That's awesome. I'm so glad you brought your folder back. Maybe you didn't do the homework assignments. That's okay. We can do them together right now, right? So it's not getting hung up on the right or wrong of something. It's more like, did they get close? Did they even try? And then we can reinforce that in the service of trying to get them moving in the direction of what we want to see for their overall health. So how do we overcome some of these obstacles? think part of it is making sure that we're sticking to the structure that's inherent to CBT, making sure that we're providing that rationale that truly has connection and meaning for the patient, and that we're not partnering with the avoidance. We're not getting suckered into, oh, well, you want to talk about this drama that happened and that would be easier for me, so let's go ahead and have that conversation. It's more like, no, I hear that was a difficult week for you. Let's see if we can tie it into what we have planned to talk about today. And then always kind of trying to reframe from that positive reinforcement standpoint any difficulties or struggles or barriers that they might be coming into, not engaging in that yes but conversation, but more of the yes and what about this, or let's come up with another solution, always in the service of how do we get them moving in the direction we want them to move in. So those are the basic components of CBT in a nutshell. Now let me go through a couple of the relapse prevention techniques that fall under the CBT umbrella. One of the core techniques that we always do is trigger identification. And remember that in CBT, we want the patients to become experts themselves. Like, our ultimate goal is for them to fire their therapist so they don't need us anymore because they know how to do it on their own. So we want them to have full working understanding of what their triggers are, internal and external, and how they're going to manage them when they show up, because triggers are lifelong. They're not something that stops. So part of trigger identification is doing the education piece with the patient to help them understand how these things are connected. So usually we provide a visual, or we'll just write it down on a notepad really quick and say, look, you always have a thought before you have a feeling, before you engage in a behavior. The use behavior, right, is way downstream. Lots of things happen prior to you getting to that place where you're right about to use a drug. And one of the things that happens right before that is usually you have an urge or a craving, and we might provide some education about what the differences are between those. But we say you usually have some kind of a craving that occurs, and that is both a feeling and a thought. And that is preceded by a trigger, and that could be internal or external. So if we can intervene at the level of the trigger, if we can do something with that and help you to be really successful at managing that trigger, or managing the thought and the feeling that follows that trigger, we're not even going to need to do with the use behavior, because you're going to stop everything downstream if you're effective at stopping it at the level of trigger. We also want to provide education that helps them to understand that this is conditioning that's occurred in their brain, that it has nothing to do with willpower or how motivated they are to change, that it's not their addictive personality, that's not a real thing, but it's the fact that, just like Pavlov's dogs, that substances, the way it affects the brain, the way it hijacks our dopaminergic system, it is so reinforcing that all the environmental stimuli that's paired with that drug ingestion, it becomes connected, that those things become completely linked. And that's thousands of things over the course of months or years of using a drug. You've got all kinds of environmental stimuli, the street where you use, the particular smell of a song, like all of these things can become environmental triggers, which are going to start that cascade of leading you to high intensity cravings to use. So providing that education can be really normalizing for patients and help them to understand, oh, they can do something about it. But first we need to have them be really curious investigators to explore what are their triggers and what are kind of the setting events. And so there, one really great technique to be able to pull this information out is called a functional analysis. And this is an example of a worksheet that we could do that pulls a lot of things together that are part of helping somebody to start to understand their triggers. So you see here is, so in the last time that you used, let's go through and collect some of this information. Who were you with? Where were you? When was it? Let's talk about some internal triggers. What were you thinking about? What were you feeling physically? What were you feeling emotionally? What were the behaviors that you were engaged in? And then what were the short-term and the long-term consequences, right? So let's help to start to figure out, what were you getting out of this? What was it doing for you? What is part of that chain? Probably a lot of the thoughts, right, that you're having when that craving is showing up. And then what is it not doing for you? What are the consequence or the price that you're paying And how do these things kind of balance themselves? So this is a really helpful worksheet that can help you to get a lot of information about somebody's recent lapse or even their overall use pattern. Behavioral contingencies are another technique that we can use to help people delay gratification and start to build alternatives to using, because oftentimes, especially by the time they end up in specialty treatment care, they've eroded a lot of the naturally reinforcing things in their life, in their environment. And so they might need a little bit of additional support to help them shift into reinforcing the behaviors that they want to see more of. And so here again, we would start with education, where we would talk to them about, look, everybody responds to consequences. And of course, people respond to punishment. But if punishment really worked, if beating yourself up and calling yourself a loser or a junkie or whatever, if that really worked, you wouldn't be here in my office. So I want to encourage you to start to shift away from some of that punishment type behavior into what can you start doing to just reinforce and reward the behaviors that you want to engage in, that you want to have more of, because the drug use itself is naturally reinforcing. We don't need to do anything about that. But what are the things that you're not doing, you're not engaging in, that you could start to put some reinforcement behind, or even me as a provider could start to put some reinforcement behind. So this is where contingency management can come in, and that's a model of care that could be applied to an entire program. Or as an individual provider, you could think about, what do I want to reinforce? My patients have a high no-show rate. I want them to come in more frequently. Well, maybe every time they come in, I'm going to give them a little raffle ticket, and that goes into a fishbowl. And once a month I draw and somebody gets like a gift basket or something, right? Even something as small as that can be enough for people to be like, I really don't want to go today, but if I go, then I get this, right? So it's a way of building in some external reinforcers that may not be inherent to what the patient is able to get in their life right now. One way that we can do a technique with the patient is to help them to do this for themselves, is to start to think about, okay, what's the triggering situation and what are those positive consequences that you associate? Why would you want to use in that triggering situation? Now let's think about an alternative. What would be an activity or a set of activities that would give you a similar positive consequence? And have them really think through so that they have a point of comparison, because simply not using or ceasing use is usually not sufficient for long-term change. That people can stop in the short term, but in a vacuum, that behavior is just going to continue to resurface. So we need to give them an alternative that they can practice, but it needs to be of as similar or equal weight as possible to what the drug is providing for them, right? So having them just kind of think through, what would this look like, right? And you could spend a whole session just putting together an alternatives to use table based on upcoming high-risk situations. Urge management is another technique that's part of relapse prevention. So again, in that kind of chain, we're looking at how do we identify the triggers and intervene there. Now, when we're getting further down and we're trying to figure out, how do I deal with those urges or cravings to use when they show up? How do I modify that stuff? Well, that starts with teaching them the skill of monitoring, whether it's if they're still using, then monitoring their use plus their cravings and urges, or if they're not using, just starting to monitor their cravings and urges and putting a numerical weight onto those things, because intensity of craving or intensity of urge may vary by situation. And so that's also going to provide them with some more information in terms of what is the most triggering thought, feeling, or situation in terms of my intensity of urge to use. And so those are things that in the short term I can avoid while I'm building up my skill set and capacity to actually be able to do something with it. So these are all examples of different self-monitoring logs that can pull together a means of, let's say I'm going to send somebody home for a week. I'm going to show them how to do this. I'm going to say, take this home and every day fill out one line. So we have an idea of kind of where were you in terms of your use, where were you in terms of your urge to use, and then what was kind of going on contextually, what was going on with you internally and your thoughts and your feelings, that we can then look at together and figure out where was that highest intensity, where was the most frequent of those high intensity urges in terms of the context of your life. And that can help us to build a really solid urge management plan. Another skill that goes along with that is called urge surfing. So when somebody is experiencing an urge, that can feel like that's going to last forever. And part of the education that we want to provide to them is helping them to understand that these things are short term. They usually last about 20 minutes, sometimes an hour at the most. And then almost like the wave of an ocean, it rolls back. And you get some relief from that. So if you can just manage it in the short term, it may come back, but it's not something that you'll be fighting ongoing forever and never catch a break from. So imagine, rather than trying to constantly be fighting that wave, if you could just surf on top of it, if you could just see this as you're going to ride over it, whenever it comes, you just go up with it, and then it'll go better. It'll get better, right? It'll relax. So you don't even have to respond to it if you don't want. There's ways that you can respond, but sometimes it's just waiting it out and knowing that it will pass. Most urges peak within about 20 minutes, usually sooner than that. But people don't let themselves get to that point to have that success. They usually act on the urge before they get to that point. So giving them that information can be really helpful, and also helping them to understand that every time they don't act on an urge, it decreases its power. So it has less intensity the more success they have with not giving into it. So it essentially stops being reinforced, right? It starts to extinguish itself when people learn more effective ways of managing them when they're there. High-risk situation planning is the last skill that I'm going to go over. And if you do nothing of the above in any of your work, this is one that I think every single provider should be making part of their routine interactions with people. This is akin to a safety plan, but it's substance use specific, and it's just like why we have practiced fire drills in our office buildings. It helps us to remain calm and know what to do when an actual crisis is happening. Now, when somebody is in a high-risk situation, that's a situation where they are very likely to use. Their senses are going to be totally overwhelmed because we've collected all this information with them. They're very aware. This particular set of people in this context, I am hands down likely going to use, right? That is a high risk situation for them. So they need to have a concrete plan that they've developed ahead of time that they can act on when they find themselves in that situation. The other thing that we want them to understand as part of this process is that this is a choice that you have. There is a difference between high risk and low risk situations, and that over time we want people to start to shift their balance to decrease the amount of time that they find themselves in high risk situations and increase the amount of time that they're in low risk situations. So starting to sort of change that social context over time by defining them in those two categories. So this is an example of a worksheet that could be very helpful. You can pull up at the end of every session. It takes like 5-10 minutes to do this, especially once you've taught the skill to the patient. And you do it every single week or every single month, like in between the time, between now and the next time I'm going to see you. What are the top 4 high-risk situations that are coming up, right? So, okay, I've got family reunion next week, so I might write that down. I've got my niece's birthday where my cousin who I used to get high with is going to be. So I'd write that down. So you write down all of the upcoming situations that the patient is pretty clear, pretty good guess, right? This is what's coming up for me. Even if it's just one, to have them start to practice thinking through down the road, what's coming up for me that I need to be prepared for. And then you talk through to have them come up with at least 3 different ways that they're going to handle that situation. One way can always include, I'm not going to go, or I'm going to leave, or I call my sponsor, or I go with a friend so that I'm never alone with so-and-so, right? You have them like be creative and think through, how are you going to handle this situation without using? And so that way they have this plan. And then they can either take a picture of it and store it on their phone, fold it up, keep it in their wallet, but they need to have it on them when they're in that situation. And so this is a really, really valuable tool that once patients get good at using can really help set them up for success when they're out there interacting in the world. So I think I already talked to this. Yeah, talking through them and kind of working through whatever that is, so that they can start to capitalize on that skill set of recognizing the high risk situations that they're entering into and what they could do differently. Okay. So that was a lot of information. Are there any questions?